She's a licensed psychologist. She's a diplomate of the Behavioral Sleep Medicine Board, and she is licensed in telepsychology. And she has, throughout her career, she's been a psychologist at the Children's Hospital of Philadelphia, as well as a faculty member in psychiatry and pediatrics at Perelman School of Medicine at the University of Pennsylvania. And then last year, joined the University of Oregon as a faculty member, assistant professor at the Bowman Institute of Children's Behavioral Health and Psychology in the College of Arts and Science at the University of Oregon. And this is in Portland, Oregon. Is that right? The Bowman Institute?
Yeah.
So that's a fascinating part of, University of Oregon is actually in Portland, parts of it. So that's great. And Ariel did a master. She did 2 masters, one in counseling psychology at Northwestern and another one in clinical psychology at Delaware. And after that, she received a PhD in clinical psychology at Delaware as well. So she has a lot of excellent background and expertise in psychology, and now she is building a research program here in the University of Oregon. So it's a delight to invite you here and to hear about your work. Thank you, Ariel.
Thank you. Thanks so much for having me. I'm really excited to be here. I think, in addition to just the draw of being at University of Oregon and the new Bowman Institute, I was really excited to have the opportunity to be located in Portland because of OHSU, because I know of the people here. Now I do know some of them, and I just really admire the work. So I'm excited to talk to you today about addressing early childhood behavioral sleep problems in families where there's a shift working caregiver, which I thought might be more of interest to this group. All right, here are my disclosures, nothing exciting, just my sources of funding. To tell you a little bit more about my lab, so I run the Behavior, Emotions, Development, and Sleep Lab, the BEDS Lab. I hope you enjoy the name because it took me way too long to figure it out. But I started my early career at Children's Hospital of Philadelphia and Perelman School of Medicine, as Steve mentioned. And, there are really 2 areas that I focus on. So first, I really focus on trying to understand pediatric sleep health disparities and the emergence of sleep problems. And we know that these disparities are due to differential exposure to adverse social and environmental factors, not because of genetic or biologic factors. I take a socio-ecological approach. This is really a simplified Bronfenbrenner's model, but it basically says that any outcome, development, disparity is a result of multiple and multi-level factors that interact over the course of a child's life. So it might be family factors, community, society. I'll show more in a bit. So we try to understand disparities, how those are linked to child functioning and then long-term child health and well-being. So some of my work, my current R1 is focused on understanding modifiable factors linked to co-occurring sleep problems in young children. I have some other awards looking at sleep disordered breathing, but as was mentioned, I'm a clinical psychologist, so really I'm an interventionist at heart. All of the disparities work is really in the service of trying to identify, implement, and disseminate equitable interventions that are also scalable and feasible. So most of my work with regard to interventions are conducted using community-engaged methods, as well as implementation science principles, which I'll talk about. Here are some examples. Today, I'm going to talk to you about Sleep Well, which is an early childhood behavioral sleep intervention. So as I mentioned, we have all of these different disparities, and this is a figure I created with Billings et al. And then have recreated in different publications. But this is really that socio-ecological model that I mentioned. We have these different child factors, including things like internalized racism. We also have all these different family factors, right? So all these things that can connect to different practices, beliefs around sleep. Work schedules is one. This started coming up when I was training as a clinical psychologist in primary care, just seeing that families sometimes struggle to implement interventions, not just sleep, but all different kinds due to any number of these factors. Of course, there are other more systemic aspects of racism and bias that contribute to disparities in particular at the neighborhood level as well. Well, why sleep in early childhood and in primary care? Why am I focused on that? Well, as I mentioned, a lot of it is derived from my clinical experience. We know that early childhood is a key developmental period. I think all development is really important, but there's a lot of change. There's a lot of neuroplasticity in early development. Executive functioning develops between the ages of 2 and 5. But we also know that research shows sleep problems are really quite prevalent, especially behavioral sleep problems in young children. So as part of my T32 that I completed at Penn's School of Medicine and in their sleep program, we looked at 205 caregivers and their 2 to 5-year-old children who were presenting to the Children's Hospital of Philadelphia primary care for either well child or follow-up visits. And we documented this. We kind of already knew this would be the case, but surprise, these problems are really prevalent. So 85% of those 2 to 5-year-olds had one or more indicator of poor sleep health. And by that, I mean things like insufficient sleep for their age, so less sleep than is recommended, problems with timing, so inconsistency and irregularity, caffeine consumption, use of electronics at bedtime. These are all indicators of sleep health. You can look at our recently expanded model of BICE's sleep health that we expanded to pediatrics with Lisa Meltzer, and it includes those behaviors I mentioned based on the evidence we have in early childhood. 63% of kids had one or more insomnia symptom. What is insomnia in pediatrics? It's a real thing. It's difficulty falling asleep, bedtime tantrums, resistance to sleeping alone when it's a problem for the caregiver. If it's not a problem for the caregiver and they want to co-sleep and it's safe, it's not in the SIDS window, it's probably not insomnia. But we also know that there were pretty prevalent sleep disorder breathing symptoms. So 1 or more of snoring 3 or more nights per week, which is habitual snoring, gasping, pausing, and breathing. When we looked at adverse social and environmental factors like household overcrowding, living at or below the poverty line, having a caregiver with clinically significant depressive symptoms, we saw that there was increased sleep problems among kids with increased exposure to these different factors. We also found interactive effects on child outcomes, meaning that children with the most insomnia symptoms, as well as the most or the highest exposure to these cumulative factors, evidence the worst caregiver reported executive functioning and behavioral concerns. And these are all cross-sectional data. This is caregiver report, but I'll just put out there in behavioral sleep, not when we're looking at sleep duration necessarily, but behavioral sleep symptoms, the gold standard is caregiver report. I use a lot of actigraphy at school. Can't really tell you if a kid has a tantrum at bedtime. Also can't tell you if an adolescent is ruminating overnight when they wake up. So all of these things, just painting the picture here. Unfortunately, sleep problems generally are under-identified and under-treated in primary care. Primary care has a lot to deal with. There's not a lot of standardized screenings available. I saw as an integrated psychologist in primary care that a lot of the treatments, including behavioral health treatments more generally, like for child anxiety, really didn't fit with the primary care model. On average, someone attends usually about 3 sessions in integrated pediatric primary care. A lot of psychosocial treatments are 6, 8, 16 sessions, so we really might need to modify. The other issue that we have relevant to equity is that most interventions in behavioral sleep for children were evaluated and developed with white, non-Latina families or more educated families. So this doesn't necessarily mean that we need to make adaptations, but this is really a key component of my work, is understanding what interventions are needed to equitably address sleep problems in this setting, this primary care setting, which we know is accessible, especially in young children, and what adaptations are needed to make evidence-based care more responsive to different family needs or circumstances. So this led to my K23, which was from NICHD. It ended in 2023, and it was a multi-phase behavioral sleep intervention adaptation project. Apologies to some of you who have probably heard me talk about this before, but we had 3 phases here. Our first phase was to really look at the evidence base for treating pediatric insomnia in young children and ask key informants, So the caregivers coming into primary care, the clinicians who would be implementing, what are the barriers, what are the facilitators? Then we wanted to use that information to iteratively adapt for downstream implementation, which I'll talk about, so we could understand whether our adaptations were working, get some more feedback from key stakeholders or key informants. And then the third phase, which I'll focus on mostly today, was the randomized trial. And that was really to inform a future larger scale trial where clinicians practicing in settings rather than trained interventionists would do the intervention in the future. So as I mentioned, I take a community engaged and implementation science informed approach. So I'll talk first about implementation science, which is really the study of how we get people to do the thing that is evidence-based in practice. That could be screening, evidence-based screening. That could be a clinical innovation like adherence to a medication. It could also be doing a behavioral intervention that is evidence-based. And we know there's a 17-year gap, particularly for psychology research, from when an intervention is thought of as evidence-based to when it's actually used in practice. So to help lessen that gap or narrow that gap, really we have to think about the end users, who would be, as I mentioned, the implementers or the clinicians and the end recipients of those interventions from the get-go. So we're thinking about what would this look like if it's scaled? I'm not here to develop an intervention with 16 sessions. I'm not sure where that would be scalable other than outpatient mental health, which has its own issues. You know, and the other thing with regard to this, as well as community engaged work, is just that you don't know what you don't know. So as I'll show you, this work was conducted in partnership with families who were living in the neighborhoods surrounding the primary care sites in West Philadelphia, which consists mostly of patients who receive Medicaid insurance and identify as non-Latina, Black, or African American. And, you know, in partnership with families, really understanding what adaptations would be needed here. Because most clinicians still, despite efforts to diversify the field, especially in behavioral health, still look like me. So I'm a white woman, I'm highly educated, I'm financially stable, I have lots of privilege. So I really don't know what it's like to experience multiple barriers and disparities in care. So these are our family partners and two of our coordinators. So we did all of this work, as I mentioned, in partnership with families who were identified through the Children's Hospital of Philadelphia Family Partners Program, which is a super cool resource that exists to help researchers partner with communities that have whatever lived experience they might be interested in. So this started, as you could imagine, with kind of those key family informants, child informants from disease-specific populations, so kids with sickle cell, for example. But since, you know, maybe a few years ago, it's expanded. The Sleep Research Society asked, like, hey, could you give a quote about your work? And so I brought that question back to our family partners. We continue to meet 3 or 4 times a year. They're compensated for time and expertise, as I'll show you. And this is the quote they came up with. So families are the experts on families. It's crucial they have a voice and the power to influence sleep research, from identifying study questions to disseminating results. It takes a village. So now we'll talk about this multi-phase thing again, just to outline it for you in another way, besides those preliminary screenshots. So as I mentioned, first, we're going to do qualitative work to really understand barriers and facilitators. Then we're going to make some initial intervention adaptations to these evidence-based sleep strategies and get advisory board input. We had caregivers who participated in the iterative adaptation, which you can see there is a total of 10 families. They gave feedback. At the end, we had a clinical advisory board, which consisted of pediatric primary care clinicians, as well as early childhood specialists, behavioral health providers, and sleep medicine experts. And then we had that family advisory board. And we got advisory board input throughout the way, and then continued to have this quarterly family advisory board input in that RCT. So briefly, I'll touch on some of those principles of community engaged work that's specific to the community I'm talking about, which I define in this study as family partners. And those were families living, again, in West Philadelphia that were reflective of and had children going to the primary care sites where we did this work. So thinking about these key principles, these are drawn from the Children's Hospital of Philadelphia program, but also a number of other scholars that really, aligned with community-based participatory research. When I say community engaged research, I'm really talking about a continuum that could range, from kind of just getting input on a one-time basis to really partnering, to having the community being the ones who identify the research question. So how we partnered in this study, as I mentioned, we gave compensation for time and expertise. We had meetings scheduled according to family preferences, dedicated time for partner identified issues. This was really important because this behavioral sleep iterative intervention coincided with the start of the COVID-19 pandemic, as well as the much needed national attention to police acts of violence and brutality and murders of Black individuals, including George Floyd. So our family partners really wanted to have time to talk about this in our groups, and to help us understand really what that meant for people living in their community, especially because in October of 2020, Walter Wallace Jr., a Black man living in West Philadelphia, was shot and killed by police right outside one of the primary care site neighborhoods. So this was really relevant. And when you think about, all of our science and like what we did to say, oh, I gotta account for this, right? Gotta account in my model. I have to see, what stressors people experience related to COVID. Did they experience racism or discrimination? How did they feel about police brutality? It was really important to think about how we were asking those questions and to really ensure that we were sharing with participants why we would do that and what we would do with their information. So, part of this was really changing the way that we delivered some of our methods or did some of our evaluations, making things more flexible. We have a paper under review right now that kind of outlines in a lot of detail all of these different changes we made in this family partnership approach. In the interest of time, I'll move on, but I'd be happy to talk about it afterwards. But this involves power, shared decision-making, feedback loops, so what changed, what didn't. When family advisors really wanted us to be able to work with children presenting with autism or other developmental diagnoses, we had to say we can't do that in this trial because we didn't have the resources to incorporate the resources for educational resources around melatonin, for example, which we know would be evidence-based for kids with those concerns. All right, so let's talk a little bit about the science that led up to this. I'm going to go through this relatively quickly, but here you can see what behavioral sleep strategies look like in early childhood, which are usually a combination of sleep health education or sleep hygiene, and then behavioral approaches. So graduated extinction, removing, gradually the parent, the tablet, whatever's needed to fall asleep that the kid is then needing overnight to get back to sleep, and managing tantrums at bedtime. And again, this is in the context of a caregiver identified sleep problem. So you can see the sociodemographic information there. I won't go through it in the interest of time. And also in the interest of time, I'm going to summarize the adaptations that were made throughout those first two phases so we can get onto some of the outcomes. Looking at the collective feedback across these two phases, we organized our adaptations with regard to the cultural treatment adaptation framework. It's by Chu and Leno in 2017. It's really just a way of organizing what you did and what you adapted. So there are peripheral adaptations, not unimportant, but those are things like changes to the delivery methods. And there are also more core adaptations, which would be changes to the strategies and or supposed treatment mechanisms. That's maybe too much writing. It's too much writing in general, but here it is. So again, I won't go into all of this, but we of course adapted for COVID-19. Everything in the RCT ended up being delivered via telehealth. We enhanced delivery with technology, so informational graphics. You'll see relevant examples highlighted in green because you might be thinking, wasn't she going to talk about shift work? Which I am. So we made sure that we talked about what if your child sleeps somewhere else in our handouts. How many nights a week are you at home? What will it be like if you're out of the home? What about when you have to go pick up child from the babysitters in the middle of the night? All these different things to really make it so that it was typical and part of the intervention and not something where people felt like, oh, I can't address this because of the shift work. We also included more cultural humility training. You can kind of see some of that there. I'm happy to talk about the content we integrated from the cultural formulation interview. For now, I'll move on in the interest of time. But some of these core adaptations that I think are especially relevant for caregivers who shift work. And again, this was really drawn out of my own clinical experience, and I'm sure the experience of many in this room, where families, are working non-standard schedules, and it can be challenging to say, you should have an early 9 p.m. bedtime. So I haven't given that recommendation to families probably since 2018. And it really is a recommendation that's out there because I don't know what I don't know. I don't know when the family gets home. I don't know whether the family doesn't have to have their young child get up early in the morning. And so they're all on a shifted schedule that works for them until the child attends kindergarten, et cetera. And as I mentioned, we, addressed shared or multiple sleep arrangements and caregivers at bedtime. So an example was suggesting a FaceTime goodnight. So if a caregiver is not home at the child's bedtime and the child, we're trying to get them not to wait up as long, like until midnight, really incorporating a video that's been recorded, a live FaceTime, a text, an audio message, something that can be shared. So we also had handouts and informational graphics. Here you can see some of the adaptations of these for shift working caregivers. A lot of it was around the body clock. So a lot of shift working caregivers really wanted to know more about the body clock and circadian rhythms. We also had this, what to do if your child sleeps somewhere else. It's like a bedtime bag, a FaceTime goodnight, change is okay. So all of these things developed, again, in partnership with family partners and through feedback from our iterative adaptation. There's another one, getting everybody on board. This is really just a checklist of a plan. And it also includes like, where else does your child sleep? So again, that is just part of the intervention itself and not something to problem solve necessarily that we aren't prepared for. This intervention was really developed to be brief because the average number of sessions is 3 in integrated primary care. It's usually a 60 or 40, maybe sometimes 45-minute intake and then a couple follow-ups. So we had a full hour intake. You can see some of the things we do there. We also provided bedtime books to everybody, including the usual care group, but this is in line with primary care practices. We had a check-in phone call, text messages. Those included reminders of families' goals, links to informational graphics, as well as links to evidence-based content like our babysleep.com website. Session 2, more text, phone call in between. And then for the RCT, we ended up having 3, like I mentioned. Initially, we tried 2 sessions and 2 calls. You might be like, why? It's because we know that a similar age group underwent a behavioral sleep intervention in Australia with John Quach and Harriet Hiscock's group in 2011. They published in Pediatrics. That was 1 session, 1 follow-up call. The second call and session were optional. So we started with 2 and we expanded. We also documented all of this in the child's medical record so that we would be matching what actual clinicians would be doing. So we had all the required elements for billing because, again, I'm not interested in making an intervention that can't be sustained in that context. For the summary of findings for phase 2, this is published, so I'll go through it rather quickly. The sociodemographic information is there. In these 3 phases of the study, this, again, we focus mostly on insomnia symptoms, but we would expect kids who had insufficient sleep if their caregiver identified it as being a problem, which is not always the case. And, our outcomes were really related in that iterative adaptation to feasibility. We had really good retention, so both feasibility of the intervention as well as of the assessment method. And this is just a 1-arm trial here. Then we had, really strong acceptability ratings as well as perceived cultural humility, great qualitative feedback about sleep improvements, but of course not an RCT, which is why we did the RCT. So I was providing live supervision to doctoral students in the iterative adaptation phase. For this phase, it was trained doctoral students. They went through, a 6-hour training with me and then group supervision. You might be like, well, is that scalable? I'd encourage you to think about all the trainees who serve as frontline clinicians in teaching hospitals. We also did fidelity tracking. We did look at actigraphy. That was really challenging for families. It's also much harder to score actigraphy with a child who has a behavioral sleep problem compared to children with insufficient sleep or with, non-problematic according to the caregiver sleep. But so that was a really kind of tertiary outcome. We had baseline and 2 follow-ups. The average time frame was about 8 weeks post-baseline and then 15 weeks. For the enhanced usual care, we gave them a sleep education handout that was readily available in primary care and had those updated recommendations. So they had the tailored recommendations, like eliminating the 9 p.m. recommendation, for example, but they didn't receive any treatment per se from our group, although they were free to get treatment elsewhere. We ended up with 97 caregiver child dyads. They were all referred as part of standard practice in primary care. You can see some of the sociodemographic features here. I will note that this is the number that were randomized and completed baseline. We had some dropouts. We ended up screening, I think, about 400 families. And then from there, looking at who was eligible, about 150. Then, it kind of drops down as we go. And this was conducted during the pandemic. Here I'm going to highlight some of our selected baseline variables, our primary and secondary. It's more like secondary and tertiary, because the point of this study was mostly feasibility and acceptability, and then looking at initial efficacy. You kind of have to walk that line in a K, especially. So this is sleep well versus the enhanced usual care. You can see really high proportion of bedtime difficulty. That gold standard of, perceived sleep problems, everybody had that at enrollment. At the baseline, a few people indicated small sleep problems, very small, instead of moderate or severe, which is natural to happen. But in analyses, we really kept the baseline rather than sleep problems at enrollment. Here you can see prolonged sleep onset latency, lots of nighttime prolonged awakenings, short sleep overnight, shorter total 24-hour sleep. And then I'll just highlight some of these variables here. So the only difference we found across groups when we did our initial randomization check was that the sleep well group or the intervention group had slightly lower scores on CBCL, which is the Child Behavior Checklist Caregiver Report of Externalizing Symptoms, so behavior problems. So all analyses comparing these groups covaried for that baseline difference. Other than that, there were no sociodemographic differences. I know it looks like a big difference between nighttime awakening duration, but these variables are highly skewed. Probably median would have been better to show, actually. And then I also want to highlight that, about 25% on average of our sample had the caregiver participating in the intervention reporting being a shift worker. I didn't actually document shift work in the family, which I should have done. It would have been much higher, I think, but these are the primary kind of caregivers who are participating in the intervention and filling out these surveys. We also looked at the CESD to look at depressive symptoms, about 30% having clinically significant symptoms according to that measure, and this was for the caregiver's own symptoms. And then using the PROMIS sleep disturbances measure for adults, we also found that there was a pretty high prevalence of sleep problems, which you would expect in a sample with child sleep problems as well. So as I mentioned, feasibility was one of our primary outcomes, and we had really good study retention, I would say, especially given that this was conducted between mid-2020 and early 2023. And keep in mind that we were working with children who couldn't be vaccinated until super late in the pandemic, because I had a toddler and then preschooler during that point who could not be vaccinated. So I thought that was pretty good. If we look at the sleep well intervention retention, which we really care about, 46 out of the 50 dyads that were randomized to this intervention did all 3 of their telehealth sessions. Of course, people rescheduled as needed, but they completed all 3 sessions, all 3 phone calls, which is a really great level of intervention retention. That drops a little when we look at who completed the post surveys, as well as the 15-week follow-up. But compared to enhanced usual care, this was largely similar. So we had no significant differences in missingness by group or patterns of missingness according to sociodemographic or baseline features. What about acceptability? So here you can see the items for this. I think it's kind of cool that about 80% of people agreed that video sessions were just as helpful as in person. At the beginning, we had to do video. We kept doing video, even though there was some return to in person, just for like some possible consistency in this work, given the context. But for all the positively worded items, you can see that the majority, vast majority, 80% or more, are endorsing agreement or strongly in agreement that, you know, these strategies will result in change, they were acceptable. That you can see a little bit of strongly disagree for the positively worded items. Those were about 2 people that kind of went down the list of all negative. We looked at their qualitative interviews and didn't see evidence of concerns, but so who knows what happened there? It could be that they didn't want to tell anyone anymore, although it was not someone who had had contact with the family, so it wasn't like a therapist interviewing them. But anyway, pretty strong ratings there. As well as for cultural humility. So this was asked with regard to the interventionist, you know, did they appreciate the family's point of view and understand their culture and background? So 80% or more agreeing with those items or strongly agreeing. So as I mentioned, one of the primary or gold standard outcomes is presence or absence of a sleep problem, and that's been used in many, many, many studies of behavioral sleep interventions with young children. Usually it's rated on a Likert scale ranging from no sleep problems to severe. No or very small is coded as a 0. Small, moderate, or severe is coded as a 1. So we looked at our different outcomes using intent to treat, mixed effects, linear growth models. We had a logit link for the categorical outcome, which I'll show you are going to be sleep problems and then difficulty at bedtime, which has also been dichotomized in the literature. And again, this facilitates comparison with other studies. So looking at sleep well, I'm going to show you, you know, their numbers. These aren't the numbers drawn from the growth models. These are from, you know, the ratings at post and follow-up. You can see the decline in sleep well with regard to sleep problems perceived by the caregiver compared to enhanced usual care. You know, these models are linear growth models. So we're really looking at the change in trajectory and whether that change or that slope differs significantly by group over time. And that's an indicator of the treatment effect. We had a 208 average decrease in odds of a sleep problem. So that's great. That's really exciting. I'm pumped. So that's a good thing. I'm happy about that. Also, really specific to this group, we had a priori identified moderators of caregiver shift work, depressive symptoms, and sleep problems. There was no moderating effect. To me, this is a good thing. I want caregivers to benefit just as much as those who shift work versus those who don't in this intervention. And same goes with co-occurring caregiver-related, you know, depressive symptoms or sleep problems. I'm going to show you some of our other significant outcomes here. I'll note the ones we tested that were not significantly different. For bedtime difficulty, which is also, you know, traditionally a dichotomized variable, we saw a benefit negative 266% decrease in the overall odds for the intervention group. I think odds ratios are a little hard to to kind of describe at this amount of them, or this magnitude rather, but it was that's a very large effect. Looking at continuous outcomes, some of them we had to, you know, do some transformation. Sleep onset latency is always skewed, but relative to usual care, we saw a moderate effect, that's Cohen's D, for reduced sleep onset latency compared to enhanced usual care. We also saw reduced night awakening duration, so not frequency, but duration, which we would kind of expect because everybody wakes up 2 to 6 times. We would just hope that these kids are able to get themselves back to sleep a little bit more quickly and or independently, depending on the family's goals for the program when they wake overnight. We found increased nighttime sleep duration per report. We did not find that for actigraphy, although it was in the right direction. Actigraphy, our family partners really emphasize should be optional for families. Families are really worried about receiving things in the mail at the beginning of the pandemic, being home. We had lots of frontline providers that didn't want to be interacting with their child as much, putting something on their wrist, When things opened up again, families were worried about sending it to school. So we were really flexible. So we have a smaller sample size with that actigraphy tertiary outcome. We didn't see any reductions in internalizing problems, so like sad mood, bad mood in young children, but we did see reduced externalizing problems. And as a reminder, all of these analyses are covariant for that group difference in externalizing that we found at baseline. No moderation, yeah, yay, I'm happy about that too. All right. What about qualitative perception? So this is a mixed method study. So we wanted to make sure that we did qualitative interviews at post. We actually did them with both our intervention group and enhanced usual care. I'm going to show you some of the themes that emerged from this qualitative work, really just broad child sleep improvement. So a caregiver saying that the child has gotten more sleep than he's ever gotten, and so have we. Another theme that emerged, which was really consistent with the qual work in the phase 2 trial, was just that family-centered care. So one caregiver says, having somebody help us think through strategies was helpful, just coming up with different ideas, different approaches that work for the personality of the toddler. So really tailoring it. And then you can see here another caregiver saying the therapists are probably trained in their approach. It's really listening to the family and getting input from the family. We also found that there was evidence of cultural humility in the qualitative feedback as well, really feeling comfortable, feeling connected, feeling heard and understood by the interventionist. For enhanced usual care, I wanted to look at whether any themes differed according to non-shift working caregivers and shift working caregivers. And you might be like, what did you ask them? Because they got usual care. It was really very similar, except we didn't ask like what got in the way of doing sleep well, what could be better. We asked them more about, how's your child sleep been? How do you see the problems? What did you do to address them, if any? Tell me about that. What got in the way? What do you think of the handout we gave you? So the caregivers who did not work shifts said that the handouts were helpful. So I basically followed what you guys put in the packet. And this is also good news because we think that some families will benefit from written education or education delivered in different, more accessible ways, like via videos, for example. Shift working caregivers, however, were more likely to endorse continued problems and not using the handout. So it really wasn't mentioned. And also, really having like no solution. So you can see on the bottom quote, a caregiver saying that, when the spouse was working night shift, they just tried the sleep training on their own and gritted through it. And there's not really been a great solution there, suggesting that maybe there aren't tailored approaches being given outside of the program as part of enhanced usual care. Okay, so thinking about the next steps for this, we're working on manuscript preparation and publication of this RCT. You'll see the results are on clinicaltrials.gov because gotta get those in. So those are there once they accept the many changes that they've requested. And then, we really want to think about additional adaptations, including extra sessions. So a lot of caregivers, when we asked them what they would change, they said they just wanted more sessions. So more, chances to check in. So things like booster sessions, which, can happen in integrated primary care, of course. I think it's a little artificial always in treatment studies to kind of say we have these sessions and no more. But, for an initial efficacy study conducted, in a pragmatic way, this was what we needed to do. Children with neurodevelopmental differences really need to be included. So we're thinking about adaptations that include more consultation with the primary care clinician around melatonin, which as mentioned does have an evidence base. This hybrid type 1 trial will be focused on understanding some of the barriers and facilitators that behavioral health clinicians in primary care, like social workers and counselors, experience when trained to implement this program. I'm always interested in additional interventions for shift working families. This is a family level intervention. It's not on the part of the employer. I have talked a lot with my buddy, Phil Chang, who many of you may know and does a lot of shift work research and is awesome. And, we talk a lot about what policies could be put into place at different employers to really help support child sleep. And those could be things like, discounts for after hours childcare, which is really hard to find late at night, for example. So that's something that I am looking toward doing some work in. There are of course limitations in what I presented, but I want to focus more on the challenges and some of the opportunities. So I think there's always this question as a clinician of balancing flexibility and fidelity to the intervention itself. And so, we can't make sure that happens, but I think monitoring adaptations is something that you can do in usual practice. It can be part of a template, what modifications were made, for example, in a clinical note, and having accountability checks. I think this is why we really need to do more of these hybrid trials that look at implementation strategies. So what's the most effective way to train interventionists in this intervention to really optimize it for fidelity and for effective patient outcomes? A lot of people ask me like, well, what group was it that you adapted for? Who's the specific cultural group or context? There are lots of people doing incredible work that is, specific to one's culture or race, ethnicity, identity features. I think there is limited time to do all of those adaptations. And I think a broader approach would be to ensure implementation with cultural humility and really focus on decision support tools that can help clinicians understand what modifications could be made and which ones might be evidence-based. There's always a concern about gaps in sustainment and translation. We did those text messages, which hospitals can do. I remember when I was pregnant, I signed up for the CDC, like mommy text messages or pregnant person text messages, because I was like, oh, maybe this would work in a study. And I got text messages that, I think I had standard data rates apply. So hospitals, send people reminders about flu. I just got a flu vaccine reminder for my daughter. They can easily send encouraging messages to families involved in care or treatments, as well as broad-based preventive strategies as part of education, and families opt into these types of experiences. So planning for implementation and those downstream factors is really what's crucial. I'm really excited to be here in Oregon, where there's more rural populations, and it's a different context in Philadelphia. I'm excited to partner with primary care out here. As part of Balmer, we have child behavioral health specialists. We have our first cohort. I didn't know. I think they're in class like right now. So we have our first cohort of 20 undergrads who are going to be trained as child behavioral health specialists. They don't diagnose. They don't treat high acuity concerns. They're more for prevention. They would be amazing as providers supporting behavioral health in integrated primary care. And those are the types of things that we're looking towards at the Balmer Institute. It has been fantastic to be here. So thank you so much. I want to recognize all the contributors and the funding sources for this work. And just happy to take your questions. And thanks again for showing up to this and for having me.
Thanks, Ariel. That was really great. There's a lot to take in. I was wondering, did the children themselves, part of the you don't know what you don't know, but they're very young, did they actually contribute to any of this? You said there were dyads, but
yeah, dyads was a unit of randomization, but the key informant groups were the family partners. Okay. So, the kids are a little bit too young. Right. We certainly had them, as well as anyone in the family who wanted to be part of the intervention was on screen and could come, and we were flexible about including multiple people. But in some of my other work, I'm working right now with some folks at Pitt and CHOP to adapt the Allison Harvey's transdiagnostic sleep and circadian intervention for adolescents who have racial and ethnic minoritized backgrounds and also are experiencing suicidal thoughts and behaviors. For that, we have both a youth advisory board, like a standing committee of kids who would reflect the end user population or end recipient population, as well as we have actually the same kind of structure in our R34 as my K. We have an initial qualitative piece where we did interviews with adolescents and did adaptation. So with older youth, I mean, with self-report, I think we usually say 8 and up. I certainly think young kids have things to contribute, but we do it in a more systematic way with older kids. It's a great question.
And then with the sleep disordered breathing, I think it was your first or second slide, at 40%
Yes.
in 2 to 5-year-olds.
So one important thing too is the nature of the sample. So our sample was primarily Black or African American, primarily living in inner city Philadelphia. So we have to think about environmental racism and what's going on there. So we have increased exposure to allergens and toxins both in the home and outside of the home that would contribute to upper airway inflammation and potentially sleep disordered breathing.
Yeah, so that
was
looks really high and concerning. But do any of your interventions address sleep disordered breathing? Any of your outcomes, you didn't report on that?
No. So this, these behavioral approaches aren't super relevant for sleep disordered breathing. They could be helpful, but I do have a couple other studies. One is we piloted a sleep disordered breathing, like sleep navigator, in primary care to help bridge the referral for children with sleep disordered breathing symptoms who are identified as part of well child care into either ENT or sleep clinic, and really try to help make that referral happen and then, get them incorporated into treatment. I think, sleep disordered breathing is tough because, it peaks in 2 to 8-year-olds. Although we are seeing more adolescents with it because of obesity. But I think there's still a lot to be done looking at what sleep health interventions could contribute. And that R01 I mentioned, that we're in our 3rd year now, that's really focused on looking at factors linked to the outcomes of co-occurring sleep disordered breathing and insufficient sleep in toddlers and preschoolers, because we know that both impact the frontal lobes. So that study should hopefully show us if there may be other factors or other levers to pull with regard to, sleep health that could be beneficial for intervention.
Okay. Can I ask my last question?
Yeah.
I can't see who else went.
I don't know.
I was struggling with minus 266% reduction in odds ratio. I wasn't sure if that was compared to the usual
Compared to
treatment.
the usual treatment.
Okay, so then the usual treatment must have started off with because you can't go odds ratio of less than 0. Can you? For a sleep problem?
Well, it's it's a reduction in their odds of having that likelihood. Does that make sense? So you can.
So your likelihood is 40% for sleep.
Just like you can have an odds ratio of over 1.00, you can have one of negative.
Okay, so it can go down to 0.5. Okay, minus 266% of 1.1. Okay.
Yes.
Okay, I'm sure it's.
Yeah. Yeah, it's the likelihood of having, a 1, so their odds reduced by 200 and whatever, 88% overall over the course of the treatment.
Thank you.
Yes. Just like you could have a 288%, you could be 288% more likely.
I can understand that. If my original likelihood is 40% and I have minus 266% reduction in odds ratio, then I'm 0.
Less than 0.
Okay. But an odds ratio of getting something less than 0. I don't know what.
An odds rate, well, so if I had a negative odds ratio, so if I had a negative let me do this easily.
It doesn't matter.
If I had an odds ratio of negative 0.60, I would be 40% less likely to have a sleep problem than someone.
Yeah.
Than a person. Does that make sense?
Yeah.
Okay.
Yeah.
Yes. Yeah.
Oh, I was just going to say, are you familiar with the Work, Family, and Health Network study that was funded in the early 2000s, NICHD?
No, I'm not. That sounds really cool.
basically, I mean, it was focused on workplace interventions
Nice.
to reduce work-family stress, but it was basically a whole family study. And so
Cool.
it included not only the employees, but the spouses, and then also children.
That's
A
so cool.
subset of children, and sleep was one of the outcomes and one of the measurements.
That's great.
Shift workers.
And shift work, right, so Debbie was, we were part of it, and I'm sitting here, like it now.
No.
But, so I had one of the centers that developed the intervention, but there's tons of papers out there that might be of interest. I mean, this is what you're doing is fantastic. I mean, this is super interesting. But you do take the, really the Bronfenbrenner, the systems approach, and this really takes it up to how
Yeah,
the
that's
work
so cool.
system
I'd love
is
to see that.
impacting the family system, is
Mhm.
impacting sleep of the workers and of the family members, including the children. So you can just Google Work, Family, and Health Network.
Sure.
Find everything about was a massive undertaking
That's
for
great.
about, it was from 2005 to 2014 and funded with over $30 million from mostly NICHD.
That's awesome. So did that looked at factors? Did you say it looked at policies as well?
It was really workplace interventions. So it we developed interventions and in the workplace and evaluated them in RCTs.
Great. That's so cool.
Yes,
I
so-
will definitely look at that.
Yeah, it is related, but great work. Fascinating work, yes.
Yeah, great work. I really like your adaptive approach. But when you go on a sequential process, you need to document every step of the way, right? And you mentioned the importance of the challenge of balancing the activity versus, the plan.
Yeah.
So can you talk a bit more about the theoretic evaluation?
About the
Subjective evaluation.
Yes, sure. So I think one thing to note is that this intervention does have a manual associated with it. So we did track, the adaptations I showed, but then there are places in the manual that indicate adaptations for different things. It's just sort of woven into the fabric, like does your child sleep somewhere else is just part of it. So it's, I would say, not an adaptation of sleep well, but an adaptation of kind of those other kind of standard behavioral sleep components. So we had two ways to monitor fidelity. So the first way was looking at therapist rated session components, like what they did during the intervention and whether that mapped on to content in the manual. That mapped on really nicely. So about, I think over 85% of what we would expect to see in session one was included in session one. I also listened to all of the sessions, which is a lot of sessions, like 46 times 3. So there we were tracking fidelity on a weekly basis and then bringing up things during group supervision, which, isn't possible really to do in practice. I mean, I think obviously the VA has great methods of train the trainer for CBTI. Pediatrics is really far behind in a lot of ways. But I think it's doable if there are key aspects of the intervention that, you feel are really important for change mechanisms that require fidelity to what it is, like stimulus control. You kind of have to do that a certain way, but some adaptations will be possible. So at this early phase, lots of fidelity monitoring. I think we need more studies that kind of decompose the different components of an intervention to see what is needed the most, but it's hard when you have some interventions that are highly personalized like this. So we would have some kids, for example, with a super shifted circadian rhythm that their caregiver wanted to change, like going to bed at 2 a.m., and they required a caregiver's presence or someone else's presence to fall asleep and get back to sleep at their sleep period. So you're doing both some change in circadian rhythms, like waking them up gradually earlier, exposure to light, and then also doing graduated extinction. So I think it can be challenging. Yeah, thanks.
So when you had 400 dietas, which you studied about.
We had 400 that were referred to us as part of usual practice. So the PCP clicked I'm going to refer them to the study, or gave them a handout. And then we tried to get a hold of them.
Okay, so did they screen out for particular reasons, or was it just not getting a hold of them? I'm just wondering how representative that
Sure.
population.
That study population, sure. Oh, a lot of it, I would have to look at the specific numbers. If I stop sharing my screen, I could do that for you and get back to you. But, a lot of times it would be a rule out for a neurodevelopmental condition, especially in the 3, 4, and 5-year-olds. But again, this intervention was really not developed with those conditions in mind yet. Although many of the strategies apply, there's just like other psychoeducation that ethically I would want to include. For not being able to get a hold of people, it's pretty representative, I think, of what happens in integrated primary care. You start out with a bunch of people on your panel who've been referred, and then some days 0% shows, some days 60% shows, sometimes 100%. You get, I think I would say, compared to kind of treatment engagement rates for integrated primary care that we have looked at in that CHOP network, it's largely similar.
I have another question. I don't need to stop. I'm intrigued on your experience about the remote or the online versus in person. So obviously they were happy with, according to the survey, with the online, but they don't know what to compare. They don't really know what to compare to. You didn't have a control group, but you have a lot of experience of in-person interviews and things like that. So what's your impression? Did you get more information through the online version than you might have got in person or in focus groups? Because when you're in a group, you may be shyer than if you're online. I don't know.
And we didn't do any focus groups.
Well, but your group, these kind of things.
Oh, with the family partners?
Yeah.
Or are you talking about study
Well,
participants?
okay, so
Because the family partners were not part of.
so the
participants.
dyads were individual
Yes,
in all of the phases.
yes.
Okay.
So we did individual interviews in the qualitative phase.
Oh,
and we did
okay.
individual treatment. Yeah, this we met as a group. And so.
Okay, so I
Yeah.
understand now. So it's very similar then. What do you think? You would have got more information online? Or
I think you get, I will say first, I think in the future, I would rather test whatever modality you want, because I think that will, my hypothesis is that would enhance engagement, because lots of our
Sure.
qualitative interviews, especially because it was during the pandemic, where like we asked about video and people were like, well, I didn't have to park, I didn't have to find childcare, I could do it on my night shift lunch hour, like if it was like at 8 p.m. or something, you know what I mean? So, but I think with young children, my preference is in person, because some of the most evidence-based like behavior change treatments of, challenging child behavior include in the moment coaching. And it's hard to do online. So we did something called Make Bedtime Special Time. So that's when we're, working with caregivers to really give positive attention to anything that approximates doing the bedtime routine. Like, I love how you're washing up, even if the kid's crying, like you're doing it. I like when you listen the first time. Coaching that in the, I think I say that like every 5 times a day. I love it when you listen the first time. Still haven't generalized. Yeah, but that's better and easier to do, especially, in person. And with the older kids, you also like targeting nighttime fears. It's easier to do with them in the room. You can kind of warm up to them. You're like, who's your like favorite person, your superhero or fairy, or, are we going to do the sleep fairy, or is it going to be Batman that going to, check in on you to make sure you stay in bed at bedtime? So I think you get more information from caregivers because they're more focused typically, and it's more flexible online, but you miss that child interaction, which I think could be really helpful.